Hello, everybody. Welcome to episode 20 of Forensics Talks. My name is Eugene Lisho, and I want to welcome everybody here today. Just a few announcements before we get started. And the first one being that I will be hosting a Click 3D photogrammetry course. Some of you had attended the webinars last week that were free, and everybody got in there. If you are interested in learning how to document and create 3D models using your camera and photogrammetry, just head over to the website. You can just go over to under the training section there. It'll say the Click 3D photogrammetry course, and you can find out some more information. Also, coming up just around the corner is the American Academy of Forensic Science Conference, and that's the week of February 15th. That's the whole week, and it's the first time they're doing a virtual conference. Much like many organizations this time around, they're forced to do this virtually. But if you're interested, it's a great opportunity. People who normally couldn't have attended, gives people from all over the world a chance to attend and listen in on some really great presentations. Also, the other one here is going to be the Association of Crime Scene Reconstruction. That's at acer.org. That's March 2nd to 4th. Just this past week, I agreed to also be a speaker there, but I've been promoting this conference as well. If you're interested in crime scene reconstruction and bloodstain pattern analysis, a lot of different disciplines within crime scenes reconstruction, then this is a really great place. Just a little thing, a note here I found is a little difficult to find, but if you want the program and speakers, you got to go down to this found here. Otherwise, it's encrypted as to where to find it, and you'll get to this page right over here. All righty. So let's get started here, and I'm going to make a quick introduction here. And today we have Dr. Alfredo Eugene Walker. He's a medical graduate of the School of Medicine, Faculty of Medical Sciences, University of the West Indies, St. Augustine Campus, Trinidad and Tobago, class of 1996. And prior to his current position, Dr. Walker was a consultant forensic pathologist in the Department of Forensic Pathology and Legal Medicine at the renowned UK government-owned Forensic Science Services Limited, based in Sheffield, England. Currently, Dr. Walker is a registered forensic pathologist at the Ontario Forensic Pathology Service, based within its Eastern Ontario Regional Forensic Pathology Unit at the Ottawa Hospital General Campus, and that's in Canada. And he holds an academic appointment of assistant professor in the Department of Pathology and Laboratory Medicine, PALM, of the Faculty of Medicine, University of Ottawa. And he's both the vice chair of the Department of PALM and its director of education. He's the lead trainer in forensic pathology in the department's residency and anatomical pathology program, and has won 2 University of Ottawa teaching awards in 2014 and 2017. In 2015, he established a successful University of Ottawa annual conference in forensic and pediatric pathology. And more recently, in 2020, he helped organize Deaths in Custody, which was organized by a couple of institutions and under his direction. And this was in direct response to the death of George Floyd in Minneapolis, Minnesota. It was more of a trilogy conference, and I attended the last one, and I found it really, something we're going to discuss today. So I want to welcome him in here. Dr. Walker, welcome.
Thank you very much, Eugene. Good afternoon.
All right. Almost didn't make it because of a court appearance, but made it on time. So thank you very much for making it on time. That's great. First question that I always ask every speaker is, I'd like you to go back to the time well before that the doctor was in front of your name, and when you were still thinking about what you wanted to do, and what prompted you to get into this particular area.
Well, from a very young age, I always wanted to pursue a career in medicine. And immediately after completing secondary school in Trinidad and Tobago, I got into the teaching profession. So I'm a trained teacher. I have a diploma in teacher training. And it took a while to get into medical school because the cost of medical school is very prohibitive in the Caribbean. And if one isn't successful in obtaining a national scholarship through the government to pursue medical school, it's almost an impossibility. Fortunately for me, the government of Trinidad and Tobago provided funding for people like myself who had already graduated from school. and had the qualifications to get into med school and were no longer eligible for scholarships. So they provided government sponsorships, which just basically covered your tuition. So I, after 5 years post graduation from secondary school, I then entered medical school, and I was in the third class of a brand new medical faculty in St. Augustine, and the methodology that was used to deliver the medical education was a concept called problem-based learning, which, in contrast to how pathology was taught at the Mona, Jamaica campus, it necessitated an early introduction to anatomical pathology from year one, in contrast to the year four introduction at Jamaica. So from my first year in medical school, we had to rotate through anatomical pathology. We had to attend postmortem examinations, and it really attracted me, because up to that point in time, I hadn't decided on a subspecialty area of interest. And just after a few weeks, my postmortem group, my autopsy group, whittled down to just myself and the lecturer who was performing the autopsy. And questions would be fired at me, not just on pathology, but on anatomy, physiology, biochemistry, etc. And initially, of course, it was a bit daunting, because you're green off the streets, and here it is, you're on one-on-one with a very senior, experienced person, and but it forced me to up my game and become better. And eventually, we became friends. And one day I said, Doc, it's my impression that you could have gone into any aspect of medicine and excelled. Why did you choose pathology? And his response made a lot of sense, in that he said, unlike other branches of medicine where you can get away with just knowing, your field in great detail and not knowing a lot about the others, because of the nature of anatomical pathology and the specimens which come from all the other different subspecialties, you have to know a lot more medicine. And so it made sense. And in my third year, that lecturer got a government scholarship to do a fellowship in forensic pathology, and which was done in Alberta. And he came back and went in post as a forensic pathologist. And by the time I graduated and was doing my internship 2 years after, I decided to do my 3-month elective in forensic pathology. And I interacted with that lecturer again. And the medical legal aspect of forensic pathology really, intrigued me, and the decision was made. So
Okay.
that was the initial starting point.
Okay. When you were, one nice thing is the internship, so it gives you real world experience. But I'm wondering if there was ever a point where you said, if there was a difference between school and then versus, some point like the real work kind of thing. Was there ever a moment like that where you said, well, this is something they didn't teach me at in class or something?
In terms of what, considering not going through with it?
Well,
No.
maybe some of the things that they don't really teach you, whether it could be anything like the time, the hours, the relationship, managing, the amount of report writing, anything like that.
No, during your, residency in anatomical pathology and fellowship training in forensic pathology, you are gradually indoctrinated to, the demands of the job. So it was never an issue, because it was an incremental progression.
Okay.
And I pursued, so after completing my internship in 1997, I did an additional year as a senior house officer in both general surgery and anatomical pathology at the San Fernando General Hospital, purely because there wasn't a house officer post in anatomical pathology. So I was officially assigned to general surgery, and of the 14 interns who had finished their internship, I was the only one who was not placed in the specialty area that I was interested in. So the medical chief of staff had given me an undertaking that he would sort something out. And after 3 months of being in general surgery, he called a meeting with the stakeholders, the head of surgery, the lone anatomical pathologist, who was also a former lecturer at my medical school, who would come down on mornings to do the postmortem examinations and grow specimens, as well as a microbiologist, to see what can be done. The long and short of it is that for the next 9 months of that house officer year, I worked in anatomical pathology from 8 to 4, Monday to Friday, and every 3 days and every 3 weekends, I took on call in general surgery. So basically, I was working in two specialties, which gave me a much better perspective on the utility of pathology.
Okay.
And I then went to the United Kingdom in 1999, did 5 years of postgraduate training in anatomical pathology. Well, it's called histopathology in the UK, histo being the prefix that means tissue. And in 2004, I started 2.5 years training in forensic pathology, which was funded by the British Home Office.
Okay. And when did you make your way to Canada?
So I came to Canada in 2011. So this year is, at the end of March, will actually be 10 years since I've been in Ottawa.
Okay. And because you've moved and you've been in different places, is it easy to transition into these other countries as a pathologist, or is there a lot of different requirements and steps you need to take?
Well, moving internationally from one jurisdiction to another as a medical doctor it's never easy, especially if you are moving to one of the more developed countries such as the US or Canada. There are barriers which are in place, such as the regulatory qualifying exams for non-native graduates, so people who are classified as international medical graduates. But fortunately for me, because of my teaching background, I was recruited by the University of Ottawa as an assistant professor on a restricted academic license. So university departments in Canada have this leeway in recruiting international medical graduates without that international medical graduate, having to undertake any of the normal Canadian qualifying exams, such as the LMCC exam, which is the equivalent to the USMLE.
Okay.
So I was awarded a restricted academic license for 5 years. The restriction only pertains to who I can work for. So I did everything that Canadian qualified forensic pathologists would do, but I had to be affiliated to this department, this academic department of pathology and laboratory medicine. And after 5 years on a restricted academic license, you are then eligible to apply for a full medical license by achieving one of three things. So one, if you stupidly decide to do the LMCC exam, which all Canadian medical graduates have to do, and you pass it, that automatically confers a permanent license. But that would mean going back and relearning all the anatomy, biochemistry, physiology, all the basic sciences and the clinical areas of medicine, which, I would have long been over with from, 20, 15 years before. The second route is getting promoted from assistant to associate professor after 5 years within the department. And the third route, which is the route that I pursued, is basically inviting the College of Physicians and Surgeons of Ontario, the CPSO, to conduct practice assessment. So this is a 360 degree assessment of your competence as a forensic pathologist over the preceding 5 years. And they normally choose a senior person within the profession who is registered to practice in Ontario to do it. And that process involves preparing a folder of 10 cases for review. It involves the assessor coming into the department and spending a day observing you perform a post-mortem examination for the first half of the day, and then for the second half, conducting a series of interviews with all categories of staff that you interact with. So the mortuary technicians, the admin assistants, your forensic pathology colleagues, the coroner, and the residents who we teach. And that is the route that I took, and I got my full license.
Okay, that's all new to me, so that's good information. And I would think that if it was me, I'd probably take the third option, which was, I mean, if you're comfortable with your skills, you just would want to say, hey, look, I can do this, you know what I mean, and then show somebody. But time-wise, what's the length of time that it takes to run through that third option or that process?
So that third option is both the second and third option requires a minimum of 5 years practice on your 7-year restricted academic license. So you could only apply for either of those after you've been here for 5 years.
I see. Okay. Interesting. Well, I want to ask you about forensic pathology. You noted a couple of things already that made forensic pathology interesting to you. What would you say is probably one of the most important contributions that forensic pathology makes to, you know, the overall investigation, or how it assists in the judicial system?
So in forensic pathology, we assist in the medical legal determination of matters in terms of determining cause of death, assisting in understanding the mechanism of death, and again, assisting the coroners who have statutory responsibility for determining manner of death in Ontario. And when we talk about manner of death, we are talking whether it's natural or unnatural. And under the unnatural category, you have accident, suicide, homicide, and if the manner cannot be comfortably pigeonholed into one of those preceding 4 categories, then we have a 5th category called undetermined or unascertained. So we assist in that by helping, as I said, to determine the medical cause of death. We contribute to the delivery of justice by either being able to corroborate a person's account of what happened, a suspect's account of what happened, or refuting their account, as well as other witnesses. And this is by, providing expert opinion, which is based on the interpretation of our findings, based on a combination of what's in the forensic pathology literature, as well as our own personal experience.
Okay.
And for the non-criminally suspicious deaths, the sudden natural deaths, especially in young persons, we also have a very vital role in identifying certain types of sudden deaths in young people, in which there's a genetic component. So you have a category of sudden cardiac deaths called the ion channelopathies, in which the heart is grossly normal and microscopically normal. So at postmortem examination, the heart looks normal, but the circumstances suggest that this is a sudden cardiac death. So we would retain the heart in those cases, send it to a cardiac pathologist for specialist consultation, examination, and opinion, as well as in Ontario, anybody who dies under a situation that we can classify based on the presentation as sudden cardiac death, we also connect fresh tissue from them for extraction and storage of DNA to do targeted cardiogenetic testing to identify any genetic mutations associated with these ion channelopathies. It would be too late for the unfortunate decedent. However, by making these diagnoses based on targeted genetic testing, if pathogenic mutations identified, then as part of our report, we will recommend that first-degree surviving relatives, so siblings, offsprings, etc., should be referred for cardiac examination, because for these ion channelopathies, cardiologists can implant defibrillators. They're called implantable cardiac defibrillators, which is the size of a pacemaker, but slightly different. And these devices, when inserted in the body, will basically shock the heart back into action if it stops beating in the future. So we can prevent further premature deaths in a family if any of these cardiogenetic mutations associated with sudden deaths are identified. As well as there are some cardiomyopathies, cardiac diseases, which have morphological changes that we can see on the naked eye and under the microscope, such as hypertrophic cardiomyopathy, arrhythmogenic cardiomyopathy, what used to be called arrhythmogenic right ventricular cardiomyopathy previously. So again, making those diagnoses is important because they are also associated with genetic abnormalities, and first-degree relatives can be referred for clinical assessment.
Okay. I was just thinking about when you were talking about, like, having a pacemaker and the different types of technology. What are some of the standard tools available to a pathologist, and how have those tools changed over the years since you started?
Well,
besides a scalpel.
Yeah. So apart from the tools which we actually use, the scalpel, the saws, PM40 blades, scales, etc., the main advancement in practice of forensic pathology over the last 2-3 decades would be the introduction of post-mortem CT scanning as a routine in some of the larger centers. So post-mortem CT allows, especially if you are in a busy department where your annual caseload is very high, it allows for the exclusion of certain pathologies based on post-mortem imaging, computed tomography scanning of the body, as well as it affords the ability to do targeted autopsies, so limited or partial autopsies. The Victoria Institute of Forensic Medicine in Melbourne, Australia, introduced post-mortem CT scanning as routine for all their cases many, many years ago. And just by doing that, they decreased their full autopsy rate by 48%. So it means that in almost half of their cases, they did not have to do conventional full post-mortem examination. And in some cases, doing an external-only examination in conjunction with the post-mortem CT would allow you to certify the cause of death without actually going into the body.
Okay.
So, for instance, if you have a 75-year-old man with a history of ischemic heart disease, diabetes, and hypertension, who is found dead in bed, there are no concerns of criminality in relation to his death. On external examination, there's no evidence of inflicted injury. You pass him through the CT scanner. After that, do a post-mortem CT, and you see features of what we call a hemopericardium, blood around the heart within the pericardial sac. Well, at that age, the main concern or the main cause of that would be a ruptured acute myocardial infarction. And given his history of ischemic heart disease, diabetes and hypertension, he would not be subjected to a post-mortem examination. So just an cursory external examination of the body together with the CT findings, that would be signed up. However, if a 21-year-old physically fit male is also found dead in bed, a post-mortem CT is done and identifies a similar finding of a ruptured hemopericardium, then at that age, a ruptured acute myocardial infarction is less likely. And you have to think now of ruptured aortic dissections, which could be associated with things like Marfan disease and other connective tissue diseases. So in this latter scenario, this case would be subjected to either a limited or a full postmortem examination, because it would then be necessary to actually look at the pathology, to collect specimen samples for microscopic and genetic analysis, because these conditions are inheritable. So again, so postmortem CT, the introduction of postmortem CT has sort of revolutionized the approach to postmortem examinations by making the examinations more focused and also decreasing the need for what can sometimes be unnecessary full invasive examinations.
Mm-hmm. Yeah, that makes a lot of sense, and in especially in busy areas where you just don't have the time.
Yeah. So in Ontario, it's only the provincial unit in Toronto that has postmortem CT capabilities. They also have a postmortem MRI. Unfortunately, we in Ottawa, we are not so fortunate, and all we have is a fluoroscopic machine, which gives us digital plain radiography, and all we can use that for is to look for retained foreign bodies such as bullets and knife tips, etc.
Is anyone in Canada looking at, for example, the virtual autopsies that was introduced many years ago? I guess that was the University of Bern in Switzerland with Dr. Michael Talley. Is anyone looking at more advanced external documentation, scanning and internal scanning, all that sort of thing right now?
Well, as I said, within Ontario, it's only the provincial unit in Toronto. I am not aware within the other provinces if any of the other forensic pathology units use it as a matter of routine.
Okay.
But postmortem scanning of the body is not going to replace the conventional postmortem examination. Right. It's a tool, an adjunctive tool that can be used to help streamline the workload.
Okay. Let me ask you a question. A lot of people colloquially will use the word coroner, medical examiner, and pathologist or forensic pathologist kind of in the same way. What's the difference between them?
So, coroner's system originated in the United Kingdom back in the 14th century. And the coroner is basically an independent judicial officer who is tasked with investigating certain types of deaths, sudden and unexpected, unexplained or violent deaths, deaths within 24 hours of admission to hospital, deaths after general anesthetic, criminally suspicious deaths, etc. So the law, dependent on what jurisdiction you are in, the law determines whether it's a coroner's system or it's a medical examiner's system. In the United Kingdom, all coroners are legally trained. They are all lawyers. And this came into effect, I think, in 2009. Prior to 2009, about 75% were lawyers and 25% were medical doctors with law degrees. But as of 2009, they all had to be lawyers with a minimum of 5 years post-graduation standing. In Ontario, we have a coroner's system of medical legal death investigation, but unlike the UK, our coroners in Ontario are medical doctors. So they are all medically trained. A few on their own volition would have done some additional legal courses, some, have law degrees, but it's not mandatory. In other jurisdictions, such as in British Columbia, from what I understand, you just have to be 18, an adult, and there is no stipulation as to whether you can be legally trained or medically trained. And I am informed, I am not too sure, that at one point in time, the chief coroner was a truck driver. And so basically, the law of a particular jurisdiction determines who is in charge of the medical legal death investigation.
Okay.
The medical examiner system evolved in the US after years of introduction of the coroner system. And the medical examiner in a US medical examiner system is a forensic pathologist. So it's not just a physician, it is a forensic pathologist.
Right.
In Ontario, the coroners have absolute control of the death investigation. They are the ones who are officially responsible for the certification of cause and manner of death. They request postmortem examinations of forensic pathologists by completing what is called a warrant for postmortem examination. So they instruct us, we provide a service for them, we provide a report for them, and the law, although we are the ones with specialist training, many years of postgraduate specialist training, they can, if they decide to, dismiss our cause and manner of death and completely change it.
Okay.
So that's one of the downsides of the coroner system. In the medical examiner system, because a forensic pathologist is at the helm, the forensic pathologist is in control. There's no coroner. And the forensic pathologist decides who gets a postmortem examination and who doesn't. In the coroner system, it's the coroner who decides who gets a postmortem and who doesn't. In the US medical examiner system, apart from deciding who gets a postmortem and who doesn't, the medical examiner also determines the extent of that postmortem examination. It could be external only examination. It could be limited examination, which would consist of an external examination, plus or minus postmortem radiography, plus or minus targeted examination of the head only, the chest only, abdomen only. So in a US medical examiner system, the medical examiner has total control of the death investigation, all aspects of it. In the coroner system, it's the coroner.
Okay.
And the term forensic pathologist just means someone who, is a medical doctor first and foremost, undergoes postgraduate training in anatomical pathology, pursues a residency, which is 5 years in Canada, 5 years in the UK, and then undergoes a period of subspecialty training, fellowship training, 1 year in forensic pathology.
Okay, great.
In the US, residency in anatomical pathology could either be 3 or 4 years. 3 years only for anatomical pathology, 4 years for anatomical and clinical pathology. Clinical pathology being hematology, biochemistry, etc.
Okay.
And in both the US and Canada, once you finish your fellowship, you do an additional year as a fellow, your fellowship year in forensic pathology, and you pass your board exams, and then you are a qualified forensic pathologist.
Okay.
Who could either work in a coroner system or work in a medical examiner system.
Okay. Let me ask you a question about your work. I mean, you've been doing this for some time now, so I mean, I don't know how many autopsies you've performed already, but I'm sure that it's quite a lot. How often do you still do something that sort of raises an eyebrow for you, where you're like, Oh, that's interesting. Haven't seen that before. Is there anything interesting that still pops up, or do you find that now after a while it's like, yeah, it's kind of the same thing?
Well, yeah, ever so often you come across some interesting cases as far as the pathology aspect of things are concerned. But what more frequently occurs is that the medical legal slant of a particular case, which is otherwise bando and standard, makes it unique. So the issues in no two stabbing cases are going to be the same.
Hmm.
Pathology may be the same, but the issues from a legal perspective may be different.
Right, right.
And that is what makes it interesting, because one of my areas of interest, subspecialty interest within forensic pathology, is expert witness testimony. Um, we have been, I was involved in it in the United Kingdom as the dedicated trainer and assessor of prospective forensic pathologists who were applying for entry on the Home Office Register of Accredited Pathologists. And since 2015, together with a colleague here in Ottawa, we run an annual moot court exercise for our fourth-year residents in anatomical pathology. And every 2 years, they get 4 didactic lectures on the theoretical aspects. Structure of the court system in Canada, how to write a medical legal report, principles of courtroom testimony, and how to handle difficult cross-examination. Because a lot of what we do translates into evidence, be it in the form of a written report, plus or minus oral testimony in some sort of legal proceeding. So you have to be familiar with how courts operate, your duties as an expert witness, the difference between being an expert and a professional witness, the types of evidence, the classification of evidence. So, you basically forced to learn a bit of, how the legal system operates in order to effectively navigate in it.
How long is the training, and about how many people attend typically?
So in the United Kingdom, the Home Office had mandated that all prospective Home Office pathologists do this mandatory course, and it was 5 days long. Yes, it was very difficult. We were, sort of confined to a very nice hotel at the cost of the Home Office, with trainers provided by the now defunct UK Forensic Science Service, and each candidate would get 5 attempts in the witness box. So we each had to submit 5 anonymized reports of increasing orders of complexity. And the first 4 are used as practice sessions. Everyone got 45 minutes in the witness box for each session, 20 minutes exam in chief, 20 minutes cross-examination, and 5 minutes re-examination. The 5th and final exercise, that's the one that you actually assessed on. That's the test. That's the one that you are marked on. And for that, they would actually bring in practicing barristers in the UK the night before the final exercise. They would be briefed by the trainers, and the next day is the real thing. You have to suit up and boot up as if you're going to court. It's all, although it's a simulated exercise, it's all done in an official manner.
Mm-hmm.
The anxiety is real, the nerves are real. And I remember when I was a candidate on it, a forensic scientist who was also on the course, because the forensic scientists also have to do it. Forensic scientist broke down in tears in the final exercise after doing well in the first 4, and was obviously failed because she wasn't ready for the real world.
Yeah.
In Ottawa, because we don't have that luxury of time, so our 4th-year residents just get 1 45-minute opportunity, because they are not being trained for forensic pathology per se. They are being trained for anatomical pathology. And the chances of being called to court as an anatomical pathologist, if you're not doing medical legal postmortem examinations are very, very slim. But
Mhm.
it is a requirement of the Royal College of Physicians and Surgeons of Canada, who has set the guidelines for their residency training. So we run it and they enjoy it.
Okay.
We get Crown attorneys to participate, to act as prosecutors, and my colleague and I act as defense attorneys to cross-examine them.
Okay. Well, let me ask you a question. So, I mean, obviously, if you're going to be working in any forensic discipline and you have to testify, it doesn't matter what discipline you're in. It's always important to be a good expert witness, because if you can be a great pathologist, but if you can't communicate your findings, that's not going to be helpful for the courts. But do you find that you get challenged at all? I mean, I would expect that you get a free pass every time you get up on the stand. You know what I mean? Like they're typically, pathologists are highly respected, doctors are highly respected. Their word is often golden. So, I mean, do you find ever that even still today, that you get into a situation where it's like, why are they harassing me for? I don't know.
So cross-examination is that part of the delivery of oral testimony that's designed to test the robustness of the opinions, the conclusions which are provided. So testing the robustness of those opinions inherently necessitates challenging opinions. So it's part and parcel of what we do, and cross-examination can be of different intensities. It can be routine, or it can be very, very rigorous and strenuous, aimed at unsettling you, aimed at discrediting your evidence or discrediting you as a person. So I actually enjoy being challenged in court. When there is no defense expert report being submitted, you know that there is nowhere pathologically that the defense can come at that is going to be of any value. And, they have to do their job for their client, which is question the opinion. So that's an inherent quality assurance measure as part of the criminal justice system, which exists to ensure that truth comes out and justice is served.
Right.
So
Okay.
personally, I don't have a problem with being challenged. In fact, it would feel odd if you go to court and you're not cross-examined.
Right. I believe I sat through your talk. You did a talk on like being an expert witness in the deaths in custody.
Yes.
Right. So I sat through that. Actually, I want to ask you about the deaths in custody trilogy conference. I like the fact that it was broken up, and there was a lot of. I only caught the last one. I think we had only spoken just before the third one.
Yeah, just after the second.
Yeah. So, and it was. Well, first off, it's a great conference if anyone wants to attend. Very broad, different topics. Everything from Dr. Judy Melinek on shooting reconstruction, right to indigenous issues and everything. So it went right across the board. But I want to ask you about what prompted you to create this conference, and how did it come to be?
So back in 2015, I established the first annual conference in forensic and pediatric pathology of the University of Ottawa. And we had successive conferences since then, with the 2019 event being taken outside of Canada for the first time and being held in conjunction with the Fulton County Medical Examiner's Office and the Georgia Bureau of Investigations in Atlanta, Georgia. And, it was fantastic. We had 109 participants from all over the world, with the furthest participants coming from as far as Australia. And prior to that, in 2018, we had the furthest participant coming from New Zealand. So for 2020, we were continuing with that experiment to have our annual conference outside of Ottawa, outside of Canada, and we had partnered with the Office of the Chief Medical Examiner in Washington, D.C., to have a 3-day conference, Thursday, Friday, and Saturday, in Washington, D.C. Everything was then in place, and then COVID happened. So, at the start of the pandemic, everything had to be canceled. The online virtual platforms were not as developed to do conferences online. So we basically canceled that in-person conference in DC. And then in May of 2020, George Floyd died at the hands of law enforcement in Minneapolis, Minnesota. And I then came up with, well, by that time we had started to explore the use of online platforms. So I reached out to Dr. Roger Mitchell, who is my good friend and colleague, Chief Medical Examiner of Washington, D.C. Actually, he's outgoing to take up a new post as Chair of Pathology at Howard. And I said, look, this international outcry in relation to George Floyd's death has basically, shone a spotlight on a very contentious area in forensic pathology. As an alternative to having our conference, which we canceled, what do you think about us still partnering and putting on a Deaths in Custody conference? And that's how it started. So we actually had the first one on the Saturday of the same weekend that our annual conference would have been. And the first one was planned in 2 weeks. Literally, 2 weeks from coming up with the concept, reaching out to the speakers, putting everything together, advertising it, and getting it out there. And we had 362 international participants from 32 countries for that first installment. We had representation from Bhutan, India, New Zealand, Australia, Malaysia, Sri Lanka. Despite it being a very unsociable hour for some of the participants because of the time differences, it was 5 hours in duration, and it worked very well. So the first one was Deaths in Custody, a comprehensive international conversation. The second one was Deaths in Custody, international case studies. And the third was Deaths in Custody, judicial considerations. And that's the one that you attended, where this was much longer. And the first half of the third installment was basically dedicated to the legal practice. So there were many lawyers and a judge. We had Judge Hatchett from famous US TV show. So we sort of covered all aspects of deaths in custody, and not just the pathology. We looked at the toxicology, we looked at the criminal prosecution, we looked at the civil litigation, we looked at the adjudication, we looked at the crime scene reconstruction, and the next one will be a spin-off from that, which was raised as a big issue in Deaths in Custody 3, which was excited delirium.
Yeah.
So in the near future, we're going to have excited delirium, fact, fiction, or fantasy, because it's a very controversial area, very controversial diagnosis, which is sometimes invoked to absolve law enforcement of responsibility in the death of an individual who has stimulant drugs on board.
I was going to ask you about that, because that's the next point on my list here, was actually excited delirium. So I'm glad you kind of walked right into that for me. But can you just talk very briefly about maybe some of the issues surrounding that? I mean, you're talking about the medical or the some of the legal issues surrounding it. But from a pathologist standpoint, what does excited delirium mean for you?
So excited delirium is basically a phenomena which has been described in the literature, which is related to the death of an individual who most times has a history of chronic stimulant abuse, cocaine, methamphetamine, who, because of being intoxicated with stimulants at the time of their death, they act in a bizarre way, which attracts the attention of law enforcement. So they can be running naked down the streets of downtown Ottawa, shouting and screaming. Of course, members of the public would place a call to law enforcement. Law enforcement will respond and attempt to apprehend them, to subdue them. But classically, once they're in this agitated state as a result of being intoxicated with stimulants, they tend to display superhuman strength. And whereas you will normally need about 2 officers who can, subdue and arrest someone without having recourse to the use of excessive force, these excited delirium cases tend to be very aggressive and possessing almost superhuman strength. So you may have 6 officers, 250 pounds, who may wrestle them to the ground in a prone position, face down position. If the victim is obese, has a protuberant abdomen, etc., these are all factors which could probably impair their breathing. And typically, once they are subdued and placed in handcuffs and placed into the van, they then go very quiet, and by the time they turn up to the police station, they are dead. So it consists of 4 phases, really. The excited delirium part. They also exhibit hypothermia due to an increase in body temperature. Then there's sort of respiratory arrest, and then they die. And the issue in forensic pathology that comes in is, was their death as a result of use of excessive force in physically restraining the victim by law enforcement, or was it due purely to the effect of whatever stimulant drug they were on at the time, or is it a combination of the two? Factor in the use of conducted electrical weapons, tasers, into that. Factored in on natural disease, so heart disease, coronary artery disease, ischemic heart disease. It opens up a minefield in terms of determining exactly what mechanism was responsible for the death and how we formulate the cause of death.
Right, very
so
interesting.
Those are not easy cases to sort out.
Okay.
As you can see from the George Floyd case, who was on the ground, prone position, with a knee applied to his neck for 8 minutes and 46 seconds, had some drugs on board, so that's a classic example of how difficult it can be,
right,
to determine cause and manner of death.
So when do you expect the conference to be? The next one? You don't. It depends.
Good question.
Okay.
When I find some time to set aside to present it, but it will be before June.
Okay. Well, keep me posted, because I'd be more than happy to help promote it here. We have a lot of people that from different backgrounds. Now, is it open to the general, I don't want to say general public, but the general forensic public, like law enforcement and?
Yes. So basically, these conferences were restricted to anyone who was involved in medical legal death investigation.
Okay.
So, police officers, crime scene examiners, pathologists who perform medical legal autopsies, forensic pathologists, cardiac pathologists, neuropathologists, toxicologists, that sort of, we didn't just want it open to the general public because of the sensitive nature of what was being discussed at the first one.
Okay. Well, you'll keep me posted on that. But last question. You didn't put it in your name there. It says Alfredo Walker, but the E is for Eugene.
Yes.
Correct? All right. So were you named after somebody else in your family named Eugene or no?
No, actually, I was brought up Catholic, and during my confirmation, we had to adopt a saint name, and I think I was assigned, or if I chose it, I can't remember where it came from, but it was adopted after.
Okay, okay, good. All right. Well, like somebody online the other week or whatever, I said, the Eugenes need to stick together. So sounds good. All right. Well, look, I'm going to we're getting on in time, but I just want to say thank you so much for your time and for your insight. Really appreciate it. You come highly respected. I always enjoy your talks and the information that you have to give to everybody. So hang back if you can. I'll come back and just chat with you afterwards. But again, thank you so much.
Thank you.
All right. All right, folks. So that does it. That's episode 20. And not much to say other than next week is going to be episode 21. And we have Michael Connolly. He's a crime scene investigator with the Boston Police Department, and he's going to talk to us about the Boston Marathon bombing and his role in the investigation. I saw a talk that he did a while back, and it was really, really interesting. So I'm hoping that it's going to be just as appealing. So on that note, thank you very much, everybody, and we'll see you next week. Take care. Bye-bye.